So I just wanted to hear your thoughts on how do you manage patients who have metastatic castration-resistant disease, somebody who's progressed now from metastatic castration-sensitive disease to metastatic castration-resistant disease.
Okay, so when you're looking at the time of progression, it depends on kind of what sort of compression. Sorry, can we start again? All right. So when you're looking at the time of progression, you look at what the patient's performance status is, what they've previously been treated with, how well they've tolerated those sorts of things. You know, if they had ADT alone, that's going to be a very different patient than the one that was treated with triple therapy up front. It also is a time where we reassess what the genomic markers are, what the NGS sequencing is, whether there's an actionable target. And then ultimately, we have a number of new options.
Yeah, you know, along the same lines, you know, I'll look at, you know, what did they receive before? You know, what is their health status, comorbidities, and then what was the treatment response before? Were they on Zytiga for a couple years or a few months, or, you know, docetaxel before, and that can kind of help guide if we're going to use chemotherapy, you know, docetaxel, cabazitaxel, or go to radio ligand therapy like Pluvicto, or even radium-223. And then, of course, if they haven't had molecular testing, you're reviewing if there's any options in that space.
Yeah, I agree. I mean, there's various options at this point, and clearly the driver is what they've received before and what their performance status is.
Absolutely. I mean, this is a very complicated space, and there are several factors that we have to consider here. I think really the most important thing that all of us have really said is that what they received in the past. What's their performance status? What is their molecular profile at this time? The nature of progression, whether it's oligoprogression versus it's florid progression. Is it just bone-only disease versus it also has visceral metastases? So we have a menu to pick from, and we have to consider all these factors. So let's maybe talk about the patients who have minimally symptomatic bone-only disease. How do you think about piece 3 data in this context in these patients?
Yeah, I think the data is impressive, you know, as far as, you know, having a potential role in this space. You know, I think in the past I haven't used it a lot because of concerns of financial toxicity, you know, for the patient, but I think that's improving, you know, with time. But certainly the overall survival, you know, was impressive, you know, with that trial.
I can't agree more. I mean, these 3 definitely has given that option to, you know, pursue that approach, and overall survival, and I think the tolerability was also pretty good.
With some increased toxicity, there was a 3-month progression-free survival, I believe, in that study, and that's impressive. Not the progression-free, but the overall survival difference. So that got my interest. Certainly, it is a new option we have available.
Yeah. So it does seem like the combination of enzalutamide and radium has become part of our menu now in this specific.
Especially minimally symptomatic.
Minimally
as
symptomatic
you mentioned,
bone metastases. How do you put in the context the data of combination of abiraterone and radium, which wasn't a positive trial? So any thoughts on that?
So I think in where I practice, I think that's not even, I wasn't even considering that, because as I said in my previous comments, I have had patients, mostly if I was going to do a doublet, was going to be abiraterone, so I never even thought or was going to consider that. But again, for academic purposes, we can keep discussing about it, but for me, it really is not even a moot point for me to consider.
I think it was interesting that in the 2 trials that the use of bone strengthening agents, you know, the Xgeva and Zometa, was far greater in the 2nd trial. Now that's something we usually look for in this space anyway, but that may have something to do with the differences.
I think this is a great point, and I think this also brings us back to the emphasis of using bone strengthening agent in patients who have castration-resistant disease and bone metastases. It's critically important for us to emphasize the need of using these agents. Because there's always a question that now with these, you know, radiums and, you know, lutetiums, do we still need to use these bone strengthening agents? In my mind, I think the answer is yes, and absolutely yes.